this lecture series is initiated and sponsored by the External Advisory Committee to the Global Public Health Minor. And the External Advisory Committee is composed of people in the community, not academics, who are doing some of these amazing things overseas. And in fact, many of the members of the External Advisory Committee are on the program for this lecture series. But some of them aren't. For example, Nancy Fitch, who's been a really important part of our External Advisory Committee, can't give a lecture this year because she's in Haiti, working on global public health in Haiti. So we forgave her for that and told her we'd miss her, but she's doing important things down there. So last year we had, I think, 14 lectures. They were very well received. And the External Advisory Committee asked me when I was putting together this year's series to come up with totally new topics, no repeats in terms of topics. Some of the same lecturers, I think there are a couple of the same lecturers, but they wanted totally new topics. And so that's what we're going to give you this semester. And so you all have the program. Or if you don't, Natalie will give you a copy of the program. And it's a pretty power-packed lineup. I don't think I'm going to go through all of the names of the people who are on this list and are going to be giving lectures, but you know, we're covering everything from nursing to disabilities to ophthalmology, dermatology, you name it. It's almost everything you could imagine is on this particular program with a global emphasis or a global concentration in terms of the talks that are going to be given. It's every Wednesday night, and then I'd like to tell you about this now. I'll be saying more about it later. But on the very last Wednesday of the semester, that's May 13th, we're planning to have a celebration event. Now, all the details of that celebration event haven't been worked out yet, but what it looks like it will be is an occasion where all the lecturers come, all the people that have talked, all the students who are enrolled come, all the students who are going to graduate with their minor in global public health come, and the members of the External Advisory Committee and the members of the Campus Steering Committee come. So that's our dream anyway, that we'll get all those people together for some kind of a celebration event on May 13th. Now, just let me tell you one little wrinkle in that program is my class that night, because it's finals week, meets at a different time. So instead of being over at 6:20, which we do, 6:30, sorry, so which we do now, it'll be over at 7 o'clock that day. So we're going to start that event at 7 instead of at 6:40, that one night. There's one other change in the program, and that just came up today. And that is I got an email from George Reese, and he told me that unfortunately, well, maybe unfortunately for us, good for some other people, he's been asked by CDC to come back to Atlanta and do some more training for Ebola workers on the night that he was supposed to give his talk. Now, the good news is he's got lots of other nights that he can, Wednesday nights that he can do it. It's just a matter of me finding somebody who's going to switch with him. I haven't been able to do that yet, but I'm sure I will. So he'll still give his talk, but it's going to be at a different time, and somebody else will be taking his time. So I just wanted to let you know that. Stay tuned. I'll announce that as we go on, and if you need to know more about it, you can email Delilah, and we'll tell you as soon as, I imagine sometime next week, we'll know who's switching with him. I think that's all I needed to cover. Is there anything else, Natalie or Delilah, that I needed to cover? Any questions, either about the program or about the course?
Peter, the public would be welcome to that last event.
Oh, did I not mention them? Of course, that's the other thing. We want all of you to be there for that celebration event as well, because you're going to rub elbows with the speakers. And, you know, I really mean elbows because today we don't, because of influenza and so forth, we don't shake hands. We use elbow bumps. You're going to rub elbows with all of these other people that I mentioned, and the students are going to be there, and they're going to want to talk to you, and we can reflect on all the lectures that went on during the course of the semester. Now, I thought it would be a good idea for me not just to talk about the course on the first day, but also to give you some of my insights. But I must tell you that I'm really an imposter in this particular lecture series, because unlike all the others, I don't work directly in global public health things overseas. I study it, I've researched it, but I haven't actually done it. So my perspective may be a little different than those of the others. Now, having said that, I want to introduce Dr. Brian Sippy, who is an ophthalmologist in town and has been a wonderful contributor to this lecture series and to my class in the past. And so he's here tonight to introduce me. I hope it's brief.
Thank you, Peter. Do I need to use your mic?
Oh, I have to stand next to you, yeah, so why don't...
So for logistics and for the recording, I need his microphone, so he has to suffer me introducing him right here. Well, I'd like to really say that, Peter says he's an imposter in this lecture series, but you're looking at an academic powerhouse in the world and of global public health and policy. So Peter has really brought me into this campus and this world of public health on UM's campus, and I've become really impressed with the breadth across campus of the student involvement and the energy here. And I'm on the External Advisory Committee, and he is right. Last year's series was really designated to be a one-time deal, but it was so successful and it was so unique with the public blend with the students that we as the committee begged him to do this at least one more time. As a senior professor, I think that he would like to pass these tasks on to somebody else one day, but he did agree. Peter is the founding director of UM's International Development Studies and of the Global Public Health minor. In the paper today, there was a description of a biology professor who was awarded the Fulbright New Century Scholar. Peter is a Fulbright New Century Scholar. If you want to know what that means, you can look at the paper today. In 2005, in the UM, he was named the Distinguished Scholar on campus. In 2011, the APLU awarded him the Maloney International Leadership Award. And recently, in 2012, he received the George Dennison Presidential Faculty Award for Distinguished Accomplishments. So you hear the word distinguished and accomplished a lot when you're around Peter. He is, again, an academic powerhouse, publishing over 6 books, 40 chapters, and over 50 peer-reviewed articles in this type of literature. He's taught in 4 countries in Africa, China, Hong Kong, and Finland. And he is a leading world's expert in migration health and climate stabilization. So, Peter, you're not an imposter. Thank you for enlightening us.
Before I give my lecture, I can't pass up this opportunity to say one thing about those awards. And that is, in some ways, the most special of all these awards was the Michael P. Malone Award that I received from APLU. And the reason that was very special is because Michael Malone, the late Michael Malone, was president of Montana State University. And so I was the first Montanan to receive that award. But I always wondered, would he turn over in his grave if he knew that somebody from the University of Montana got that award? "Where's the corpse?" the burial worker shouted, kicking open the door of the isolation ward at the government hospital here. The body was right in front of him. A solidly built young man, sprawled out on the floor all night, his right hand twisted in an awkward clench. The other patients, normally padlocked inside, were too sick to look up as the body was hauled away. Nurses, some not wearing gloves, and others in street clothes, clustered by the door as pools of the patient's bodily fluids spread to the threshold. In the next ward, a 4-year-old girl lay on the floor in urine, motionless, bleeding from her mouth, her eyes open. A corpse lay in the corner, a young woman, legs akimbo, who had died overnight. A small child stood in a cot, watching the team that took the body away. As the team moved around, they stepped around a little boy lying immobile next to black buckets of vomit. They sprayed the body and the little girl on the floor with chlorine as they left. A chilling scene from Makeni, one of Sierra Leone's largest cities, as reported by Adam Rossiter. What I'd like you to think about tonight is, what can we learn about global public health from the 2014-2015 Ebola outbreak? WHO's Director General Margaret Chan called the Ebola crisis likely the greatest peacetime challenge the United Nations and its agencies have ever faced. Last September, the UN Security Council adopted a resolution with an unprecedented 130 countries as co-sponsors. The resolution defined the Ebola outbreak as a threat to international peace and security, and urged countries to provide health experts, field hospitals, and medical supplies. UN Secretary General Ban Ki-moon appealed for $1 billion in aid to tackle the pandemic. He later raised that appeal to $1.5 billion, of which only about $800 million has been received in commitments to date. So this is the outline of what I'm going to talk about this evening. I'm going to talk about some basic facts about Ebola. Then I'm going to get into transnational governance, which as a political scientist you might not be surprised I would talk about. I'll talk about critical interventions, and then some conclusions about global health with some recommendations and some lessons. Let's review some basic facts about Ebola. First of all, the disease has zoonotic origins. There's increasing evidence that the index case for the outbreak, this particular outbreak, was a toddler in Guinea who caught and played with long-tailed bats in a hollow tree near his house. Ebola has very gruesome symptoms in its later stages. I've listed some of them from this thing you can see: headache, bleeding from the eyes, not in all cases. And one of them that's not on this list is uncontrollable hiccups. That sometimes happens as well. But the early symptoms are difficult to distinguish from malaria or typhoid fever. Demise or improvement typically occurs around 7 to 11 days. By today, there are more than 21,000 cases in this particular outbreak. And the epidemiologists say that for every 100 reported cases, there probably are an actual 120. More than 8,000 people have died. The mortality rate can be as high as 90%. This particular outbreak, it's lower than that. It's around 70%, although it varies widely by country, by area, and by age. One of the facts that I found out was that if you're over 60, your chances of dying from Ebola are about 96%. Liberia has the highest number of deaths, but it's slowing in Liberia. In Guinea, it's still spreading. It's now in twice as many districts as 2 months ago. And Sierra Leone has the highest number of cases, and Sierra Leone is particularly problematic because of an increase in the number of recent cases in the capital city of Freetown, and because outbreaks have moved to the western part of the country where treatment units have not yet opened. So in other words, the hotspots are emerging in new places. WHO official Bruce Aylward has said, and I quote, "To get to zero, you have to find and isolate every case. And MSF, Médecins Sans Frontières, this week has pointed out that there are critical gaps in tracing contacts that could lead to new surges of Ebola in this, what we call the Ebola region. Well, next, let's talk about the incubation period. So the incubation period is, I'm sure you've all read this, 2 to 21 days. But usually it's 5 to 7 days. And this is important because Ebola is only contagious when clinical illness develops. This slide shows you how Ebola can spread. It's not airborne. Most of it comes from bodily fluids. And in the Ebola zone, bodily fluids are everywhere. So you have to be very careful when you treat patients or when you take care of bodies. And so you need a very complex set of gear. And the CDC has increased the complexity of this gear over time. But this gear is not easy to work with. Masks tend to fog up, it's hot, and it's exhausting. And so almost everyone who dons these outfits have said that the maximum time that they can have this gear on is somewhere between 45 minutes to an hour. And then they have to take a break. And if you're working outside, you wear much the same kind of gear. This next slide is what the Red Cross burial teams are wearing in Liberia. So that's one problem, but the next problem is when it comes time to take this off. It's also very complex and challenging because in some cases we think people have actually been infected during the process of removing their outfits. So you need to take very special precautions and follow a rigorous protocol when you're removing your protection. So let's move now into the focal countries. By and large, there's 3 focal countries with regard to this outbreak. It did go to Mali for a little while, but that's been fixed. And the 3 countries are Sierra Leone, Guinea, where it started, and Liberia. Now, the problem is with these 3 countries is that there were some really influential compounding factors that led to the spread of this outbreak to the extent that it has occurred. So I wanted to review some of those with you so you get some idea of the determinants of this kind of an outbreak. Not the disease itself, because that comes from zoonotic origins, but from the outbreak. So first of all, there was a brutal civil war in Sierra Leone, and that ended in 2002. And Liberia had its own brutal civil war. That ended in 2003. Well, Guinea didn't have a civil war, but what did it have? It had coups, it had a lot of political instability. And so in the end, all 3 of these countries were left with devastated economies and devastated health systems. And maybe just as important, a legacy of distrust of government. The existing healthcare system then was far too rudimentary to cope when the Ebola outbreak occurred. So let me give you some statistics on that'll demonstrate this. Let's take Liberia, for example. Before the outbreak, Liberia had 1 doctor for every 100,000 people. And Sierra Leone had 2. Now, just to put this in perspective, I thought of comparing that with the United States, but I decided let's pick a country of about the same population size as Sierra Leone and Liberia. So I picked Croatia. Croatia has about 284 doctors per 100,000 people. Let's look at nurses. Sierra Leone and Liberia each had about 1,000 total nurses and midwives. at the time of the outbreak. Total. Croatia has 25,500. Bit of a disparity. With no running water or soap, no protective gowns or gloves, no workers to clean up and provide ancillary services, many of the scarce doctors and nurses who were willing to treat the infected in a facility lacking basic infection control practices, guess what? They caught the virus. They infected others, and they died. And from the work that George Reese sent me, I've noticed that this is a pretty common pattern with Ebola outbreaks, that it's the care providers who contract it and then pass it on and then die. And that's particularly devastating when you start out with such a small base like these countries did. A New York Times special investigation report on Guinea said this, and I'm quoting, "There were so few beds and so few staff to treat or isolate Ebola patients that doctors found themselves stepping over the dying and the dead in hospital corridors." Now, if this wasn't bad enough, there weren't very well-developed, in fact, sometimes totally absent, tracking opportunities in these places, tracing opportunities. Contact tracers, when they did exist, often weren't paid on time, and so they quit. And then cultural practices exacerbated these conditions. One estimate is that perhaps as many as 20% of all of the infections in these countries arose from touching and washing infected corpses while grieving at funerals. Now, if you think about it, is that a very unusual cultural practice? Well, in some ways it is. Probably the way it plays out is a little bit different. But on the other hand, it's not uncommon around much of the world to wash corpses, to touch and even kiss loved ones in a coffin. Now, this outbreak exploded when it reached impoverished and densely populated cities. That's the big difference between this Ebola outbreak and the others that preceded it. The others were contained within rural areas, small population centers. A 39-year-old Liberian man reflected that Ebola was worse than the Civil War. Here's his quote: "Even when you're fighting war at that time, you know the safe place to go. This one, you can't even know where to go. Ebola eliminates families. It makes you go far away from contact with your family." So there was little awareness, and that resulted in fear. Fear of the doctors, fear of the Médecins Sans Frontières people, and just last week, fear of some priests that led people to, and sometimes try to get rid of those people to evict them. But more commonly, it meant that people preferred their own hands-on caring and taking care of people at home. Why? Well, because if they sent someone to the treatment center who might just have malaria, remember the symptoms are very much similar, that person was likely to contract Ebola at that center. And they knew that hardly anyone left those centers alive. And if you did happen to get cured and leave those treatment centers, and very few people did, then what happened to you on your return? Well, what happened to you was families spurned you, neighbors fled. Here's a story in The Guardian from Liberia last November 24th. The surviving 6 children were stigmatized by the rest of the community. Old friends no longer wanted to see them. They could not go to the mosque to pray. And community members forbade their children from associating with the orphans left behind. The children could not even buy anything from the market because no one would accept their money. This next slide, a very recent one, is about some Ebola patients who were discharged in Liberia. And what I wanted to show you here was not only the discharge, but the prevalence of mattresses. Do you know why there are so many mattresses there? Well, the reason is because when somebody has Ebola and their bodily fluids are the way in which the infection spreads, their mattresses are suspect. And so all the mattresses of Ebola patients are burned. And so when they are sent home, they're given a brand new mattress to avoid that particular problem, or to substitute for what they had before. So now a few things I want to talk about in terms of transnational governance. So I want to talk about the UN and WHO. I want to talk about some of the others that were involved in this outbreak, the World Bank, NGOs, bilateral efforts, and then I'll take it home to the US government. Because it's a transnational challenge that overwhelms the capacity of any single country to contain, Ebola shows why we need the United Nations. In Secretary Ban Ki-moon's words, Ebola matters to us all. At the same time, the crisis has revealed weaknesses that stem in part from UN priorities. One of those is WHO's staffing. At the time of the outbreak, WHO had one technical expert on Ebola in the whole worldwide program. The Africa region's budget had been cut from 26 million in 2010 to 11 million for 2014 and 15. 9 of its 12 emergency response specialists had been laid off. Now, WHO's total approved budget for the two-year program budget for 2014 and 15 is just under $4 billion. And it's important to note that of that $4 billion, only 23% of it are assessed contributions. The rest are voluntary contributions subject to donor whims. Now, by comparison, and I could use the CDC by comparison, by the way, CDC's budget is about $7 billion, but I picked the peacekeeping forces of the United Nations. The peacekeeping forces two-year budget was just above $7 billion. I'm sorry, CDC is 6. The peacekeeping forces is 7. And all of this, $7 billion, is mandatory and assured. Incidentally, there are about 6,000 UN peacekeepers still serving in Liberia. So WHO has its own issues. And Dr. Chan blames the largely independent African Regional Office staff for its slow and disorganized initial response to Ebola. This is a region where the top jobs have not been awarded based on competence, but on political favors. In addition, WHO's central coordination capacity had shrunk, partly because of its resource constraints. So initially, it was not clear which part of WHO was in charge. Now, there's a newly elected African office director, and she is Dr. Matshidiso Moeti, a Botswana physician. And she'll take office next month. Will she make a difference? We'll have to see. So the World Bank. Now, the World Bank's in an interesting situation because global health is a special interest of World Bank President Jim Yong Kim. Some of you may know that he worked with Paul Farmer for many years and helped set up Partners in International Partners for Health. And then he went on to be president of Dartmouth, and now he's president of the World Bank. So he committed early on $4 million, partly to pay the hazardous duty salaries of frontline local health workers who are taking huge risks, and partly to speed the deployment of international health workers. Now, under Dr. Kim's leadership, the World Bank Group has mobilized nearly $1 billion in financing for the countries hardest hit by the Ebola crisis. And their economies have been seriously damaged. As you can imagine, when there's quarantine, when travel is cut off, when no tourists want to visit any longer. In fact, one of the things that's so interesting and disappointing is the ripple effect of Ebola. So even though almost all of the effects of Ebola are limited to 5, 6 maybe African countries. Other countries that have never had a case of Ebola have suffered as well economically. Ghana is a good example. Ghana usually has totally full hotel rooms. Right now they're running at about 30% capacity. Ghana's never had a case of Ebola. So, non-governmental organizations, and there's quite a list here as you can see, but of all of these, we have to say the kudos go to Doctors Without Borders, or Médecins Sans Frontières. Early on, MSF was the only group to declare the outbreak unprecedented in scope and to issue an urgent call for a massive response. By the end of September, MSF operated 6 facilities with 532 beds. They had 239 international volunteers. I thought it might be interesting, in case any of you would like to go and volunteer for MSF, to know what the salaries are. So MSF pays you $1,700 a month. They require that you take 6 weeks off from your job. They'll pay you $1,700 a month if that's your first time. They'll probably up it a little bit if you go more than once. They had 2,900 local employees. Another voluntary organization, the International Medical Corps, had 275 confirmed international volunteers, and they pay a lot more, $4,500 a month. So if you're going to go, you might want to link up with IMC. And Partners in Health also is involved. They came on a little bit later. That's Paul Farmer's organization. The Red Cross mostly does body management kinds of things. And then there are many faith-based missions that are working there. And Microsoft contributed $100 million. And there are others that I didn't track down. So what about the bilateral government kinds of efforts? Well, I think, first and foremost, and we should be very proud of this, and I think, frankly, I think we should make more of this, is the United States efforts. Not just this one, but I'll talk more about its financial contributions as well. But what Obama promised early on was to send 3,000 military personnel, 200 civilians, and to build 17 100-bed treatment centers in Liberia. The first 3 of these were completed by the end of November. And the Liberian military and the Marines are working on 10 others in various stages of completion. The U.S. also promised to train 500 local healthcare workers a week. Now, MSF has said that's very unlikely. And the reason it's unlikely is because families don't want their children to go to work in these treatment centers, even if they're going to get trained and paid, because they don't want them to come home to their house at night. And so they don't have a place to stay at night. And we were going to conduct a population campaign on how to handle exposed patients. I don't know how that's going. And you can see from this slide that there are other countries involved too, and including East African countries that probably don't get as much recognition as they should. And here's a picture of the Marines when they arrived in Liberia getting their temperature taken in October. I thought this was semi-humorous. No, the military is not all we have to offer, even though that might appear to be the case. Now, domestically, the CDC, the Centers for Disease Control and Prevention, are our primary domestic responder. And the CDC also helps out overseas. At the state level, many governors, you might remember this, initially imposed mandatory 21-day quarantines for arriving travelers and medical workers who had contact with Ebola patients. The prime example of this was Casey Hickox, the MSF nurse, who at first was quarantined and then later allowed to go home to home confinement. President Obama has asked Congress to provide $6.2 billion in funds for West Africa and to strengthen U.S. defenses against the disease. I believe that Congress, before they adjourned last session, allocated $5.4 billion of this request. So some global health conclusions. Ebola is a tough and complex challenge. West African healthcare systems have been overwhelmed. Essentially, they collapsed. The few existing isolation wards are overcrowded. There's a severe shortage of healthcare professionals and facilities in these three countries. Ebola remains uncontained and could become endemic in these three countries. As WHO discovered, this is a virus that can go into hiding for some weeks, only to return again with a vengeance. Researchers have identified at least 22 African countries that have the ecological conditions and social behaviors that put them at risk of future outbreaks of the Ebola virus. Last month, MSF warned that the bulk of the work of tracking, isolating, and treating patients, raising awareness to minimize contagion, and burying the dead still rests on an overworked and insufficiently prepared core of local doctors, nurses, and volunteers. And as a consequence of the concentrated Ebola campaign, other illnesses increasingly are unattended. So we have what is called an emergency within the emergency. There's a decline in child vaccinations. People suffering from malaria, typhoid, pneumonia, and so forth can't find an open clinic to go to, or they're too afraid to go to one. But there have been some positive developments too. The United Nations and other actors, especially MSF, were able to mobilize a massive global response. The transportation revolution aided the spread of Ebola. That was offset to some extent by the communication revolution, which facilitated a response to the Ebola outbreak. There's been more scientific research, and there's greater clinical understanding today of the pathology of the Ebola virus. Ways to improve survival rates have improved as well. Just a week or so ago, WHO posted a paper, the first of what they say will be 14 papers. And this paper was called Ebola in West Africa 12 Months On. And it talks about some of the lessons. It talks about a number of things, but one of them is the lessons that WHO has learned. And I thought I would share some of that with you tonight. The first lesson is that multiple reinforcing interventions are needed. You can't just do one thing. So to go on and explain that. Aggressive contact tracing will not stop transmission if contacts are left in the community for several days while test results are awaited. Good treatment may encourage more patients to seek medical care, but will not stop community-wide transmission in the absence of rapid case detection and safe burials. In turn, the powers of rapid case detection and rapid diagnostic confirmation are diminished in the absence of facilities for prompt isolation, and I would add laboratory testing. And those facilities have to be air conditioned in order to keep the specimens viable. The second lesson from WHO was about community engagement. Community engagement is the one factor that underlies the success of all other control measures. Contact tracing, early reporting of symptoms, adherence to recommended protective measures, and safe burials all are critically dependent on a cooperative community. In several areas during the outbreak, communities continued to hide patients in homes and bury bodies secretly, even when sufficient treatment beds and burial teams were available. So community leaders, including religious leaders as well as tribal chiefs, can play an especially persuasive role in reducing high-risk behaviors. I think that's a very important lesson. What about quarantines? Experience also showed that quarantines will be violated or dissolve into violence if affected communities are given no incentives to comply. Well, think about it for a minute. People can't be expected to do as they are told if the effort leaves them visibly worse off instead of better off. So, for example, let's say somebody's going to tell you you're going to be quarantined without food and you're going to sleep in the same room with a corpse for days. Finally, WHO found that culture always wins. And as culture always wins, traditional beliefs and practices need to be worked within, not aggravated. So here's some other recommendations that I'd like to suggest for you tonight based on lessons from this outbreak. The first is that WHO needs reform. The regional directors need to be more accountable to headquarters. There has to be greater transparency, and WHO needs more resources. Director General Chan, on the 25th of this month, which is, 3 days ago, said that WHO needs a dedicated contingency fund to support a strengthened team of epidemiologists for detecting emergency diseases and to support rapid responses to outbreaks. Secondly, we need increased research on vaccines and cures. Thirdly, we need to stop the spread of Ebola. We need to get to zero in Guinea, Sierra Leone, and Liberia. Secretary General Bond has said the best way to stop the spread of Ebola is to stop this virus at its source. And that means we need many more doctors and nurses. We need people like Dr. George Reese and like the St. Pat's ICU nursing director Kate Hurley, who were sent to Sierra Leone by WHO early on, and then trained 200 Cuban doctors and nurses after they returned. And we need more local health workers, more burial teams, more vehicles. The numbers I have on this slide were November estimates. I think they're probably still pretty accurate. So WHO in that January paper had some recommendations of its own. And they said it's important to establish fully functional emergency operations centers that have local government health teams integrated and playing a leadership role in each country down to the district and prefecture levels. To get to zero, these countries will need high-quality surveillance, rapid and complete case finding, and comprehensive contact tracing. And it's also important to restore public confidence in the public health system. And that's a place where the traditional authorities can help out. Pierre Piot was one of the members of the team that discovered the West African version of Ebola in 1976. And he said, arriving too late on this particular outbreak was a bad mistake. Leaving too early, before strengthened health systems are firmly in place, would be harder to forgive. So we need to think about the long term. And in the long term, we need to substantially improve basic healthcare systems in Africa. And in this regard, I'm particularly proud of Nancy Fitch, who spent, after she retired as director of the Student Health Center here on campus, spent the next about 8 years now working on building up healthcare clinics and centers in Africa, and now she is in Haiti. As the Ebola epidemic has shown, capacities to detect emergency and epidemic-prone diseases early on and mount an adequate response need to be an integral part of a well-functioning health system. There are two additional long-term recommendations that I would like to suggest tonight. One is, this month this is a recommendation that came from the World Bank President Jim Yong Kim. He called for the establishment of a global pandemic emergency financing facility. Now, this is important not just to finance improvements in healthcare, but to help these economies bounce back from the devastation that they've occurred as a result of the deterioration of trade and all of the other economic consequences. And secondly, and this one I particularly like, it came from the Secretary General of the UN, establish a corps of transnationally competent health workers modeled on the UN peacekeeping forces who could be deployed on short notice to stem outbreaks. And Secretary General Bond calls this the Corps in white coats. So I looked for the Corps in white coats. And, well, that's not a white coat, is it? It's a blue coat. But he couldn't call it the Corps in blue coats because the peacekeeping forces are already the Corps in blue coats. So he called it the Corps in white coats. Anyway, we'll take it, whether it's a blue coat or a white coat. And I think you also have to do capacity building, not just treatment, but capacity building, because remember, a lot of the burden is still falling on the local providers. And some of these providers, many of them have been killed by the outbreak. So there needs to be new people trained to take over. And I always like to say, don't forget, we're going to need competent morticians as well. That's a very important part of this whole outbreak, is to have people who know how to handle bodies when they have been infected. So let's move a little closer to home. Are U.S. medical institutions and staff and public health systems able to avert or contain an Ebola epidemic? Questionable. Are we vulnerable? Well, this is the conclusion of an AP review at the end of October of last year. And they said the U.S. healthcare system, especially small and medium-sized hospitals and overextended emergency rooms, are unprepared for Ebola. Now, this slide shows you the Texas Health Presbyterian Hospital in Dallas, where you might remember the Liberian who had Ebola was first treated, and then a couple of nurses were infected as a result. So they made multiple mistakes. And this hospital was relatively well endowed, as hospitals go. Most U.S. hospitals are not equipped or staffed by trained workers. And do you know how long the average wait in an emergency room is in the United States right now, without an Ebola outbreak? 4.5 hours, average wait. So you can imagine, if you're waiting around with Ebola for 4.5 hours in an emergency room, how many other people are likely to get infected. After Dallas, therefore, the preferred strategy has been to transport infected patients to one of 35. They've now, remember, for a while there was only 4, and one was St. Pat's. Now they say St. Pat's isn't one, but there are 35 of these specialized hospitals with specially trained health workers, isolation units, and access to experimental treatments. Still, our experience to date is troubling. Brian, you're going to appreciate this. In October, while doctors and nurses at Emory University Hospital in Atlanta worked to keep 3 Ebola patients alive, the county threatened to disconnect Emory from the sewer lines if Ebola waste went down the drain. The company that hauled medical trash to the incinerator refused to take anything used on an Ebola patient unless it was sterilized first. Couriers would not drive the patient's blood samples a few blocks away for testing at the Centers for Disease Control and Prevention. And then to top it all off, pizza places would not even deliver to staff members in any part of the hospital. This is taken from a New York Times article on 14 October. Oh, that's not bad enough. Perhaps there's something out there that's even more threatening, and that is what has been called Fearbola. I can't deal with this Fearbola that's become a second epidemic, said Rocky Mountain Labs Associate Director Marshall Bloom last October. I don't know what to do for the people who don't go to the CDC website, but go to Twitter or Pinterest and places where the information is frankly not only not very good, it's deliberately misleading. And I would add that CDC itself and other public health officials also need to receive further training in what we call risk communication. And that has a lot to do with transparency. Well, what about quarantines? Would quarantines be effective in this country? Well, the ACLU has a position on this, and their position is coercive measures like mandatory quarantine or people exhibiting no symptoms of Ebola, and when not medically necessary, raise serious constitutional concerns about the state abusing its powers. Who qualifies for experimental treatments or limited supplies of a vaccine? How many negative pressure isolation units exist in our community? Well, these disturbing issues and others are treated in what I think is very compelling fashion in the film Contagion. So for those of you who are students in my class, we're going to see that film and we're going to talk about some of the lessons that we can gain from that. But Fearbola is definitely one of the key factors in that particular movie. So we've learned that Ebola and other current and future global health crises affect all of us in one way or another. In a December talk at the University of Montana, David Hammond, who has worked with the Defense Threat Reduction Agency and the Office of the Secretary of Defense's Africa Policy Unit, called Ebola, and I quote, an indication of things we have to look forward to in the next 10 to 15 years. As with SARS, HIV, MERS, everyone's health today is transnationally interdependent. Now I decided to, it's kind of, you could, I suppose, say that what I've been talking to you about tonight is kind of depressing. So I decided to end on an optimistic note. And so I made a deliberate apparel choice coming here tonight. I picked apparel from a country that has a good record in dealing with Ebola. And it's one of the few that's been declared Ebola-free in Africa. And I wondered if anybody could guess what country my shirt is from. Any guesses? Nope, not Mali. Nigeria, okay, very good. So what was the key to the much lower death rate and the rapid success that Nigeria had in stopping the spread of Ebola? Well, there were several. One, strong tracking. Two, isolation of those exposed. Three, aggressive rehydration, and that's something that people are talking more and more about today. And then, perhaps most importantly, a strong, existing domestic health system with competent health workers. And this is where I hope all of Africa will be in the next 5 or 10 years. So I'm ready for questions.
How did those ladies know your shirt was from Nigeria?
Well, there are only 3 choices, okay? The 3 choices are Mali, and I already said it wasn't Mali. Nigeria, and what's the last choice? The other country in Africa that has been declared Ebola-free but had one or two cases. Senegal. Okay, it could have been from Senegal. My ex-wife was from Senegal, but this was a gift from one of my colleagues from Nigeria when I was teaching there. And I only bring this shirt out on special occasions. Anything else? Come on, questions, yeah.
There's a hand up down there. I really like what you said about how culture is so important in transmission of this. Do you think culture is going to change because of this crisis? Do you think it's powerful enough to actually change the way that people act?
That's a really good question. Ryan, if I remember right, you're an anthropology major, right?
Riley.
Yeah, Riley, okay, yeah.
I'm a community health major.
You're a community health major, okay. Same thing. And, you know, it's a very good question because I think it will. I think that funeral practices are going to change in these countries as the awareness increases. So it's interesting because the public health campaigns were criticized because they were so negative. They would put posters up and people were told, if you get Ebola, you're going to die. Don't touch corpses because you're going to die. And so people began to think that they don't want to get anywhere near a hospital or a treatment center where they might get this disease because there's no hope. So they had to back off and change that. But I do think there was a part of that effort was to try to get people to think twice about funeral practices. And I think that's where the community leaders, traditional leaders, and so forth can play a very important role. There isn't any question that they've been able to trace innumerable, the spread, in particular the spread from rural parts of this region to the cities, to women who were bathing corpses at a particular funeral. They can find the DNA of the Ebola to make sure, to find out that that's exactly where it came from. So, these estimates of 20% of all cases having come, they may be a little high. I don't know how they can be that accurate, but clearly that would be a very important first step. So yeah, it's kind of interesting, isn't it? Because while we have to think about how to work through culture, culture isn't static. Culture changes. And so people in these countries have to think about what they may have to do to change their cultures at the same time. So that's why I was so glad you asked that question, because there's two sides to that.
And you think that just community organizers and stuff, and those types of people would be the ones kind of initiating this change, but it sounds like priests are kind of being stigmatized.
Well, the priests,
I feel like that would be an important.
yeah, the priests that were beaten and chased were Western priests. So that's why they were seen, there's been this association with when you don't, it's just a problem of awareness. And people think that anyone who comes from outside of Africa is bringing the disease because they see them associated with people who are dying. And so that's why you get some of this, those kinds of responses, I think.
Yes, I have a question. I guess my question is two parts. Number one, are there other diseases similar to Ebola which will, appear on a periodic basis? And then the second question has to do with the American issue that right now that we're dealing with measles and the whole thing in Disneyland and kids getting measles and parents not vaccinating. And do you draw any kind of parallels with the Ebola situation in that?
I haven't thought through all the implications of the second one, but I'll take a stab at that. But first of all, yes, there's Marburg disease, which is very similar to Ebola. And then there are things like MERS, the coronaviruses, SARS, that also have zoonotic origins. So there's this whole field called newly emerging diseases. And many of them, we had a person, I think his name is Dodzik, I can't remember for sure, who came into this very room and gave a talk about 8 or 9 years now on zoonotic newly emerging diseases. And so a lot of this is partly because of interface between humans and animals, but also because as we clear more forests, there's more contact with these kinds of diseases. So we know some of them, there might be some others out there as well. As far as measles is concerned, it's interesting because I was having my annual checkup today with my primary care physician, and we talked about measles. And he was saying, one of the things that's surprising about measles is we don't know how to treat measles any longer because it hasn't been around for so long. So there's that kind of the dimension to the problem. But yeah, vaccines, inoculations have been thrown by the wayside, and maybe we need to rethink that, and maybe we need to think about our own preparations for, well, one of the things that, one of the things that people say about Ebola is how many cases have we had in the United States? You can count them on one hand. But measles, we have 59 in California right now. So it's important. I think Ebola gets a lot of attention because of the horrific symptoms that are associated with Ebola and because of the mortality rate. Those are the two things that, but yes, we have to think about what's going on within our own borders, but we also have to recognize that these tropical diseases have been understudied and underattended to for many, many years. The number that used to be bandied about, it's probably changed now somewhat, is 90 and 10. That 90% of our resources in terms of research went into studying 10% of the world's diseases, and the ones that were tropical were not part of that 10%. So we got to do both, is I guess where I'm coming from on that. Yes?
If Ebola is of zoonotic origin, is there a concern that there may yet be some animal reservoir out there that has to be dealt with?
Oh, there definitely is. Ebola has not disappeared from the animals that are there. It's just a matter of time before it'll come up again. And there are 4 different strains of Ebola, and so one was primarily in Zaire. That's not the one that's here in West Africa. There was one in the Philippines. That hasn't appeared for quite a while. But it's just a matter of time before it'll come out again. I don't think anybody's trying to eradicate it by killing all of the wildlife in West Africa like they kill all the chickens that have been exposed to bird flu. No. But what they want to do is they want to have a rapid response, especially when it's most likely to break out in a rural area, because that's where you have the most interface between humans and animals. So if you can rapidly respond and respond in the correct way without getting the healthcare practitioners infected, then you can stop it in its tracks. But you're not going to eliminate it from the reservoir of all animals, I don't think, no. And I don't think we should try, because that would be, that would be rather unethical, it seems to me, to try to kill all the bats and all of the bush meat that people eat. Yes. Sorry.
Oh, I was listening to an epidemiologist on the radio when this was really at its apex, I guess, of conversation. And she was so confident that a vaccine would be developed, and she wouldn't give a timeline, but she really felt that a vaccine would be developed in a fairly short period of time. Is there any?
That's out of my area of expertise, but I would hope so. But on the other hand, remember, there's 4 different strains.
Yeah.
So, and the other thing is, it's not easy to vaccinate in these remote rural areas where the most likely contagion is going to take place. So, that would be it'll be challenging. I hope it happens, but it's challenging. It's not going to be simple. It's probably not going to be quick.
I can tackle that. So there are vaccines, and what's frustrating about the 90-10 that you mentioned is that Dr. Feldman's vaccine he developed when he was still in Winnipeg, it's been around for 15 years and was never studied in humans because there are much more pressing issues like malaria and tuberculosis and HIV, et cetera, where most of the research money was going. So there's 6 different vaccines that are undergoing clinical trials in humans right now. And 2 of them have advanced to field trials in Africa now, and actually are starting in February. And one of them is the one that Dr. Feldman has developed, and another one is another one that the NIH developed. And those field trials are going to be targeted first at healthcare workers because they're, as you mentioned, on the front lines. And the hope is to vaccinate as many as 30,000 people and get more safety data as well as efficacy data. And the problem is, what's very frustrating is that it takes so long to get these things going, is that now we're seeing a tapering off of cases at the same time as you want to see if the vaccine works. And the only way to see if the vaccine works is to give it to somebody and then let them get naturally exposed. And if the exposure is going down, then you're stuck with surrogate markers for immunity, and that's always not nearly as satisfying.
And the other thing I've read in that connection is that, correct me if I'm wrong, they're going to skip the idea of giving people placebos for a control group because that would not be ethical.
It doesn't go down well.
Right.
That's right. So, but the most recent iteration, it continues to evolve, just as you say, was that it was going to be a 3-arm study where placebo was one of the 3 arms. And I don't know if that may have evolved since then. That was like 2 weeks ago.
So I guess we're done, and I'd just like to say I hope that what I've had to say tonight kind of sets a tone for the lecture series, but not necessarily a depressing tone. I don't want it to be a depressing tone. I think that the people you're going to hear from the rest of the semester are people who have really enlightening and uplifting kinds of stories to tell you. So stay tuned for the rest. Thank you very much.